I'm really excited about our guest, Dr. Carmen Black, who is going to be giving us so much insight into what's going on in the field of medicine and how that intersects with racism. But we don't have a lot of time because Dr. Carmen Black is extremely busy, and we'll have to go soon. So we're going to jump right into it in just a second. But I do want to thank each and every one of you for your continued support of our content, of our chats, and of all the work that we've been doing to really elevate the issues that are important to our communities. I was not with you, unfortunately, on Tuesday. And to be honest with you, I can't remember why. I know it was a good reason. So I could have been caught up doing some other work. But I'm with you. I'm with you today. And I'm so happy that I get to share this space with each and every one of you that are listening now. And we'll be listening later on. Do us a favor. And if you're watching this on LinkedIn Live, we want you to share it with your network. If there's a group that you're a part of that lifts up social issues like these, we want you to share it out to that network. Comment, engage with us. We want to engage with you. We want to hear you. We want to connect with you on these chats. If you're watching from Facebook, please do us a favor and share this message out as well, and comment below and really continue to support the content. So, as mentioned, we have Dr. Carmen Black in the house. And I get the privilege of introducing her, reading her bio, and highlighting some of her work. And then we're going to jump into the topic of today, which is the intersectionality between racism, mental health, and medical care. Let's jump into it. So, Dr. Carmen Black, assistant professor of psychiatry at Yale School of Medicine. She's the director of social justice and health equity, education, and adult psychiatry. She's fiercely proud, outspoken, family oriented African American physician, a strong supporter of racial diversity and medicine. Dr. Black is actually a native of Augusta, Georgia, and an honored second generation graduate of the Medical College of Georgia. She was trained in psychiatry by both the University of Pennsylvania and by her alma mater, MCG. She joined Yale School of Medicine as the assistant professor of psychiatry in September of 2019. And our primary clinical appointment is at the Connecticut Mental Health Center. There, she is able to marry her dedication to provide clinical care to racially minoritized populations with academic research. Her research interest focuses on promoting racial diversity within academic medicine, um, as well as specifically racial and mental health discrimination within daily clinical practices. She's also a proud mother of two amazing children. And we got to chat a little bit about that from mom to mom. So I'm really excited to really introduce Dr. Black to us. Dr. Black, thank you so much for being with us and for sharing this space with us today.
Absolutely. I have to warn you, my code switch died. So don't ask me a question if you don't want to know the answer.
Well, listen, we're chatting, so I want you to be as authentic and real as you can. That's what this is about. We want you to bring your full self, and we that's what we honor, that's what we love, that's what we want. So give it to us raw.
Hey,
Sounds like
listen.
it. Well, I feel like I'm chatting with my girlfriend right now. So let's just talk about what's the journey been like. You're a African American doctor, young, female, also happens to be a mother of two amazing children. What has that been like for you? And that's a loaded question, so take it however you feel.
Oh, it's an exercise of toxic stress, stubborn perseverance, and secret eye rolls. It's
Mhm.
very interesting to function in spaces where equity and diversity and equal treatment are professed, but the behaviors are anything but. And then if I say something contrary to the status quo, as an African American descendant of enslaved persons, I only represent 1% of medical faculty, so my voice is easily overspoken by colorblind, whitewash nonsense.
Wow. I mean, that's so loaded. That's so loaded, right? And I think, you hit on a number of things. We don't have enough time. We're gonna have to bring you on like five other times. You hit on colorblind. You hit on, that the idea of when we are in these spaces, especially you being in a field where only 1% of us is really represented, and so essentially the drowning of your voice could be oversaturated by the whiteness of the industry, right? But then also it really, in essence, is like another job.
Unpaid, unrecognized, unpromoted. Um, and as all of these isms stress me to slap out, then medicine has the disrespect to publish racial disparities papers about our blood pressure, about our BMI, about our. I'm like, oh, really? I got stressed by myself? Oh, okay, thank you.
Tell me about that. Tell me about the intersection, or how the racialized trauma and racialized stress that's connected to racism. How does that impact things like blood pressure and health and all those things that they talk about but don't really deal with the root of it?
So, to this idea of colorblind, race neutral language, so medicine has created the term social determinants of health to describe poverty, to describe, single parent households that don't have the income to get things done,
Mm,
and all of the things that negatively impact health. But they're not so keen to say that racism is that which overly concentrates Black folks into the bucket of social determinants of health. So they
mm,
want to use race neutral language, right? Oh, it's not because you're Black, it's because you have risk factors of poverty. It's because you have risk factors of this. I don't know why you have them, but here they
mm,
are, right? Instead of just saying racism,
mm,
because racism requires some form of accountability.
mm,
Because if you look at medical providers as individuals, and certainly the medical industrial complex as a system, we're the most wildly racist thing on the planet. Yet, our identity imposed on ourselves and imposed by society is that we are healers. So, how do you
mm,
reconcile the fact that we're traumatizing people with this need to be seen as a
mm,
healer? And so, what happens in the space is that there's a bunch of racist elephants in the room, and anyone, particularly the 1% of myself who has the history of 400 years in this country and all this other things, that your perspective is a little bit different than the status quo. When
mhm,
you try to talk about the racist elephant in the room, it gets overspoken with more colorblind nonsense. So
mhm,
it's an exercise in a secret eye roll, because I can't say the purest form of what I'm thinking, because mama needs that paycheck once a month as well. So I
mhm,
have to wait till I can write it in a publication, because only through white normative, white recognized publications do I have permission to know what I already know. So I'm an overly published author, mainly because white normativity doesn't give recognition to what I know without that endorsed publication line.
yeah. When I'm listening to you, it really reminds me of suffocation in its purest form. Being in an environment, having the level of intelligence and intellect that you carry and that you possess, but not being able to express it in the level in which you can because of the color blindness and the environment, which is very restrictive of people like us.
Mhm.
The other thing that comes to me that I really love to distinguish anytime we have these conversations is there is a very clear distinction between the BIPOC community, communities of color, and African descent individuals. And it's important to make that distinction, because I think a lot of times when we mesh our lived experiences together, we miss something, and it's called intergenerational trauma.
Yes.
Right? It's the trauma, the cycle of trauma that has been passed down from generation to generation, that also, and it really it support our system as a society, our policies, our practices, our methodologies, it really is the one that's really passing that trauma down. So it's not just Black families that are just like, hey, let's pass the trauma. That's what we do here, right?
Correct.
No, it's the systems, the structures in which we live, right? And our medical structure, our healthcare system, our criminal justice system, all these systems are responsible and accountable for passing down this intergenerational trauma. And I think that's a really important distinction to make, especially in the within your industry, within in medicine, because I'm not a doctor, so I'd love to hear from you, but how there will be how that may play out even within health wise. So for African descent individual versus BIPOC or a person whose descendants may not have been derived from slavery in this country. What does that look like? What's the distinction, if any, that you've seen in your work?
Whew. Let's see. We got 13 minutes. All right, girlfriend, let's get it.
Just spit it to us like a
Look,
drive
I
by.
need a Chianti right now. Sit down on the clock. So it plays out in so many ways. So to your point of unique identity, even amongst the BIPOC, part of medicine's problem is that anything not white, cis, het, Protestant, privileged gets thrown into a pot of other, and they call it DEI. And
Mm,
anything that doesn't fit any one of those identities gets thrown into a giant, like, shake and bake bag, and you just shaking it and just shaking it, right? You lose all of the unique individual qualities
mm,
necessary towards acknowledging history that
mm, mm,
sticks today. So even amongst the Black folks in medicine, Black doctors of academic faculty are 3.6%.
mm,
But amongst that 3.6%, experientially speaking, here at Yale, I would say that less than half of the Black identifying physicians are actually descendants of enslaved persons. There's room at the table for all of us. Only white supremacy would try to say that we're in competition with our brothers and sisters. But
mm,
as far as that intergenerational 400 years of this very unique American anti Black
mm,
racism, it is the descendants of enslaved persons who are experimented on by US medical systems. It is
mm,
descendants of enslaved persons who
mm,
had their medical schools closed in
mm,
1910 when they said we weren't good enough. It is descendants of enslaved persons who did the civil rights movements to integrate things as much as we did. Again, white supremacy would try to say that we're in competition, but what we're doing in the name of equity and diversity is they still want the well qualified Black folks,
mm,
right? So they're not going down to Martin Luther King Boulevard and
mm,
uplifting the descendants of enslaved persons,
mhm,
because that intergenerational educational trauma, family trauma, it means that our white normative test scores and white normative performance is less than. But what they can do is there is a whole African ancestry world
mm,
sending its top minds to be allies here, and that is wonderful. But it's not the same as going down to MLK and helping those of us who've been doing this for 400 years. And the history, the trauma footprint, I call it like the carbon footprint of American trauma. It's
mm.
all very different.
I you need to like just trademark that trauma footprint. My first time just hearing it in that way, in that context, and I think it's so profound and so powerful because that really is what it is. It's a trauma
Yes.
footprint. It can be traced down hundreds of years, and I think you talked about accountability. I think that's really the key. We don't want to be accountable, right? The ones responsible for this, for the trauma footprint, for the enslavement, for the intergenerational trauma, for the systemic poverty, the concentrated, the structural racism, and all these isms and that really derives from racism. We don't want to be accountable, and we want to turn a blind eye. And we think by ignoring, turning a blind eye, and then meshing us all into one melting pot where we're losing the accountability. But I think it's important that we call it for what it is. We address the all the elephants in the room.
Mhm.
in every industry and consistently, until systems really change. And I think it's really interesting because Dr. Luhart, your colleague, last year we had a panel with him, and he said racism, and I thought this was really, really insightful, and I never seen it this way. But he said racism actually started in medicine. He said they were the ones that invented racism, and he's like, even the way the skull was looked at, and the way they compared a black person's skull to a white person's skull, and all these other racialized algorithms
Mhm.
that have been developed that people don't know anything about. Blacks being experimented on, you mentioned that. And so we're not crazy. We have gone through pervasive trauma, especially within medicine. And so there is such a mistrust and a failure that has happened in that, between blacks and their interaction and their care and access to medicine. And so I'm wondering if you can speak a little to that, Dr. Black, and then if we can touch a little bit on what's going on right now in our political climate with the coerced care, that'd be great too.
Absolutely. So, again, to this idea of a trauma footprint. So, healthcare providers, again, seeing ourselves as healer, and then society puts pressure on us to be healers, and we're all type A personalities where we want to check the boxes and be the best. So much of the focus is to fix Blackness. Blackness is the problem to be solved. It's not ourselves. And so if Black folks don't trust us, oh, I need to go convince them that I'm trustworthy. We're
Hmm.
not cultivating trustworthiness by acknowledging the 400 years of anti-Black trauma. No, that takes a little bit longer. My job, and you always hear the narrative, let's go down to the churches and get them to trust us. Huh?
Hmm.
What internal work have you done in yourself, in your practice? If a
Hmm.
busload of Black folks showed up to your clinic, what have you done not to make them all the next disparity paper in JAMA?
Mhm, mhm.
They don't want to hear that part.
That part.
That
That
part. That.
part. Because it's exactly what happens. Whenever, I'm thinking about the vaccinations and what happened when we wanted trust. We knew that these communities of color and Black, especially Black communities, weren't trusting of what was going on with vaccines. And so what they did was they went into faith-based organizations and they partnered with them and said, make them trust us. We don't want
Yes.
to hear about the 400 years of slavery. It's gone. It's over. It happened. To
Hmm.
tell them to get over it. Get over it. We just need them to trust us so we can give them this vaccination. They need it. That's just really what it is. That's the extent.
Yes.
We don't want to sit down. We don't want to listen to them. We don't want to come to the table. We don't want to hear their pain. Because it makes us feel guilty, and we don't
Right.
want
And
to
it
own up
takes
to the behavior.
longer.
Yeah.
And it takes longer. But also to that, so this idea of Blackness as the problem to be solved, what medicine, I'm a medical educator at one of the most highfalutin places. Thank you, Yale, for writing my check. Thanks, boo. Okay. With my homage. Okay. But what we like to do, this is before my Keontae. You ain't met Dr. Black. Hold up. So what
I
we'll
love it.
do is that this huge pocket of racial disparities papers, like let's look at the word racial disparity. That means there's something about my race, my Blackness, my hair, something about me and you that creates this disparity. It's not racialized pay
Mhm.
homage to the systems that are doing this. No, no, no. We're going to use that colorblind racial as if
Mhm.
Blackness is the problem to be solved. And while they're teaching students how to be good doctors, this is how you walk like a doctor, right? They're teaching them to be clones of little white men because all of the profession is steeped in centuries of white, male, cis, het, privileged men.
Wow.
And so there's no honor to diverse approaches to medicine. If I were to approach a patient when I was back in training and refuse to code switch, such as I refuse to code switch now, my evaluator, who's there's a 96% chance they have no footprint in my history, gets to say,
Mhm.
oh, you're too casual with patients. Oh, oh, you're this, you're that. And it's called medical professionalism. You
Mm,
are the face of the good doctor because the good doctor looks like this,
mm,
unspokenly a clone of an old white dude. And what medicine does is normalizes these racial disparities, right? So we have gold standards how to teach good doctors, but the good doctor ignores half the country. Half the country because half the country ain't even going to be white in a couple of years. But
mhm,
already between gender minoritized folks, sexually minoritized folks, racially minoritized folks, that's the majority,
mm,
right? But
mm,
JAMA will write us. Researchers will get promoted writing the umpteenth paper of
mm,
whatever ism disparity, right?
mm,
Medicine loves counting up dead black folks. Oh,
mm,
look, more dead black folks. Oh, it's a racial disparity. Oh, there was 20
mhm,
dead black folks for COVID, right?
mhm,
But
mhm,
will we deliver justice to them?
mm.
No. We pat ourselves for meeting gold standards of being the good physician with medical professionalism, competency evaluations, and all that jazz because we have normalized death to all others.
Hmm. This is so. I'm taking notes, Dr. Carmen. But when I tell you this is so profound, we don't have enough time to cover everything. But what really resonated with me was when you were talking about the idea of, being trained as a doctor and being cloned as a white male. Essentially, is really what your training consists of. um, and the training of millions of other, how many other doctors out there. And it's so scary to even know that that is the training. Um, and it sounds like there's a lot of inherent work that needs to be done, even within curriculum, within training, with the residency programs, within universities, and all these other things to really ensure that medical care looks like culture humility
Mhm.
and doesn't look like a a one size fits all. You gotta
It's
use
forced
this one.
assimilation of how to be the good doctor.
Yeah.
Again, paying homage to the one who writes my check. Thanks, boo. Yeah, thanks. They're paying for me to do an entire master's in medical education, where my thesis
Mm,
is medical professionalism as a tool of white supremacy. Because again, you can say whatever you want about someone who has a culturally authentic physician excellence, who has
mhm,
a diverse approach, who is a physician advocate, activist
mhm,
against inequity. Because remember, medicine wants you to normalize and passively accept death to minoritized persons. They don't want you to be an activist because the activism requires that you go against the status quo. And
mhm.
then their inherent authority on the hierarchy structure of medicine gets challenged. And so my project will be like collecting the narratives of racial equity minded folks of all backgrounds and collecting the narratives of racially minoritized folks, Black and Brown especially, in medicine, and just hearing, has medical professionalism been used to discourage, dissuade, or reprimand, remediate your cultural authenticity or your physician activism?
That is so. And so with your project, are you targeting the medical professionals and patients or
Medical students, because they've been normalized to this hierarchical structure of forced assimilation the least, and they're the closest to their root of authenticity. And I want to document the process where it gets essentially like beat out of them through remediation and reprimand.
because I guess the assumption would be, I guess, are all doctors starting off with this mindset or with this approach, or does it sort of, are they essentially cloned into it or
Well, they
through
recruit us for our differences and then teach us how to be the good doctor, but the definition of the good doctor hasn't been updated.
For how many years?
I mean, ever. I mean, the good doctor could be the one out there with the fro and the casual clothing who's engaging their Black male patient in a way that really the patient responds to. So, right now, the idea of the good doctor is physician centered according to white normativity. But what if instead of normalizing the adverse outcomes of half the country, what if we said the good doctor engages all of their patients and adapts themselves according to the patient's needs,
Mm,
right? So if I have a little old white lady, she's still gonna get Dr. Black, but I am like in the room reading her engagement. I'm still not code switching, but I'm adapting myself to meet her needs where she's at. But at the same time, if I'm talking to someone who's another Black single mom living the life, Dr. Black's going to look a little bit different, right? Because I want them to know that there's a human being at the end of that physician title. And if there's a human being, then human beings give a damn,
That's right.
right? And
That's
so that's how you earn someone's trust. You're in the room with them and sharing humanity. That's not what medical professionalism is teaching us to do. They're teaching us how to act according to physician standards instead of act according to what the patient needs us to be.
You know, it reminds me of a story as we're wrapping up. I love everything that you're saying. My daughter, one day, probably shouldn't be telling this on live, but one day had to get stitches. Let's just say she's a very adventurous child. Likes to flip and so forth. And so I won't tell the freak accident how it happened beforehand, but we took her to the hospital and she had to get stitches. And I remember the doctor that was going to do the stitches was a Black woman, and she had like a little what do you call it, one of the scars. She had a scarf on her head, you know, one of those scars when you're home, you sort of tie.
Mm-hmm. Mm-hmm.
And I loved it. And she just came in, and I'm like, oh, is the doctor? She's like, what's going on over here? And when I tell you, made us feel so comfortable. First of all, I was gonna pass out in that room because I can't take blood, especially not with my baby. So I almost felt they were gonna have to put me on the bed and put a little oxygen, mask on me because it was just a mess. But when I tell you, because she was in the room with me and because she was exactly what I needed and my daughter needed, we were able to get through that procedure in a way that was empathetic, was humanizing, it was empowering, and it was one of the best experiences that I've had, and within the healthcare system, and that sticks to me. That really that stuck with me for a really long time. But it was so profound because I just remember the connection that I felt to this doctor. She was in the room with us. We weren't. My
Yes.
daughter wasn't just a patient. She was She was a Black girl, Black little girl who hurt herself, but she was also her. She saw herself in her, and my daughter was able to see herself in a doctor. And I
Yes.
think for me, that really, you can also feel the difference because the quality of care is different. And let me tell you, she did such a great job. I'm telling you, them stitches healed up within days. You
Right. And
another
it's
case,
not just because it's culturally authentic. It's because I could have a white person. And if a white person comes in and I see their humanity and they see mine, outcomes will get better. So medicine likes to paint that Black patients have better outcomes with Black doctors because there's something magical in the Black skin. No, it's because we're connecting with humanity. Someone can be purple with green spots. As long as you talk to me where I'm at, I be cool.
That's it. And I love that. It really is. It's about humanity. And in the world that we're living in, I know we have to go, and the political social climate that we're in right now, the world we're living in right now, humanity is almost becoming is extinct. And the way in which we are having these approaches that are essentially stripping us from our humanity.
Hmm.
And we didn't get to talk about the whole issue with the legislative agenda, what's going on in New York City, which I'm not sure if you've been following the news, Dr. Black, on that, but essentially mentally ill patients at the discretion of NYPD or police officers will be hospitalized against their will if the police officers deem that they are a danger to themselves or to others, but they're the ones making that assessment without the obviously the training and the education to do so. And so we didn't get to talk about any of that, but if you want to leave with any last thoughts or just any words on what's going on, because I know that's a really hot topic right now in New York City.
Yeah. So first and foremost, call me. I can come back. It's what's up. And then, just know that there's those of us within medicine itself, not just external, but those of us exist inside the institution trying to change it from within. So when you see a provider that you really appreciate, give kudos to their boss because we really risk exposing ourselves to white normativity and white supremacy to bring authenticity into the room. I was remediated in my residency for clinical incompetency, insubordination, and being called unprofessional, which is why I'm doing the professionalism project, because I literally resigned from that training program because of all the frackle knackle. So just know that we exist, and when you see one, give some kudos because your kudos go a really long way for folks trying to change it from within.
I love that. And thank you for your work, for what you're doing. It's a breath of fresh air. It's what we need in the world. And it really is, you're trailblazing. You're setting the trend. You're blazing a trail for many other Black females that are going to come after you and follow in that footprint. And we're going to recreate a new footprint. It won't be a trauma one.
Mm-hmm.
It won't be a trauma footprint. We're going to create new footprints that's really going to help to change things from the inside out and really bring real restoration and healing to our communities, both mentally and medically. So I'm grateful for you, for your work, for what you're doing, and for the legacy. I know you're going to your leave, and now we consider you family, Dr. Black. so you
What's up, boo, sister
so you
friend? Yeah.
so you're drafted in, and we have a Gen Z program. I'll leave with this: a Generation Z program. It what it does is it targets certain careers, medicine being one, and it helps to provide a career pathway for our teenagers, our Black teenagers, to have access to these careers from early on, from high school. So we connect them with doctors who take them under their wings as mentees for a semester, and they teach them insider knowledge. They train them, and they shadow them in their workplaces, and then eventually we help to get them into universities where they can pursue these careers. This is really how we, on the long run, right? In addition to the great work that you're doing, Dr. Black, looking at our generation that's coming up under us and really providing these mentorship programs and its access so that we can be represented better in these fields. There's no reason why we need to be 1%. There
Nope.
It's insane. We need to completely bring that number up, and this is one of the ways that we're doing it. So it's called Generation Z, and the program right now is hybrid. We have an online version of it in addition to an in-person version in the South Bronx, at two of our partner schools. So if there are any parents that are interested in signing up for that, or any doctors or nurses that are interested in being a coach or a mentor to a high school student in New York City, please reach out to us. Let us know. We'll take great care of you, we promise. But Dr. Black, I appreciate you. You are super amazing. I don't want to leave you, but you got to go to work, and I got to go back to work too.
Girl, I just got that text message. My patient's here. What's
You got to go. Okay, patient is
I'm not
here.
trying to fit that stereotype of that doc who makes you wait all day. No, not that. I mean, I'll fit some others. The angry Black woman, sure, but not that one.
I can't. Well, Dr. Black, give it up for Dr. Black, everybody. We love her so much. She's so iconic, and just she's a gift to our world. And so I appreciate you, Dr. Black. This will not be your last time. We'll have you back on again, and we know you got to get to your patients. So thank you so much. Thank you for sharing this space with us.
Absolutely. Y'all take care.
Thank you. Bye, Dr. Black. And thank
Goodbye.
you all for watching and for listening and for tuning in. We do want to wish everyone happy holidays. We know that the holidays are near and coming up. We hope you did your shopping and didn't spend too much money, but hope you did your shopping and are spending this holidays with family and friends and loved ones. And I am hoping and praying that this holiday is filled with nothing but joy, peace, and love to each and every one of you that are watching. I love you. I appreciate you. Thank you so, so much for sharing this space with us. Until we see you again, we will be back on next week. Again, happy holidays and stay safe.